We will start our session in a while, but before we do that, just like to give you a brief introduction. With us is today Dr. Asma Abdus Salam, and her topic is acute post-surgical pain management. And she is currently working as a assistant professor, a consultant anesthesiologist, and pain physician at Ziauddin Hospital, Karachi. She also holds the position of director academics anesthesiology at the Ziauddin Hospital and is supervisor at the STSP as well. She also has is the immediate past general secretary of Pakistan Society of Anesthesiologists in Karachi for the Karachi chapter. Also, she has has established acute and chronic pain services at Ziauddin Hospital, Karachi, and seek grant of IASP developing countries in 2021 and completed it in 2022 on pain education of nurses. And she has organized and conducted multiple workshops on pain management, basic pain assessment, and on ultrasound guided regional anesthesia. So I will hand over this presentation and the session to Dr. Asma, and we'll start the session today. We have a good audience today. Welcome.
Thank you so much, Ziridba, for the kind introduction. Thank you so much, STSP, for inviting me over and giving me a topic on acute post-surgical pain management. It's only on the recent updates and guidelines, and I'm really thankful to all of you to be here at 9 p.m. because I know it's too late. But for education, I think everything is good. So without any further ado, I would continue my presentation, and I don't know why it's frozen. Can you guys see my presentation? Yeah. So I have nothing to disclose, and I hope that most of you are already doing pain in any capacity, like either you are a pain fellow or you are a consultant. So this is the definition of pain, which was designed by International Association for the Study of Pain, of which the STSP is also one of the collaborator. And we have been using this definition for, I think, more than 2 years now. So I'm not going in detail of it, but whether it's acute or chronic pain, the concept starts from this definition. And all of us, we classify pain either by its physiology, whether it's nociceptive, neuropathic, or inflammatory. We all know that majority of us, they do classify pain according to the intensity, which is either mild, moderate, or severe, or according to the time course, which is acute or chronic, or maybe by the tissues affected, which is either the skin, pain, viscera, joints, and etc. But as today's topic is on acute post-surgical pain, and we know that it's a kind of a nociceptive pain, so we will go on from here. The etiology of acute post-operative pain is, we all know that it's multifactorial, and the surgical procedures, they usually causes injury to the tissues when the surgical incision is being given. The surgical injury, it may trigger a myriad of the responses in the pain matrix, which can start and which can vary from sensitization of the peripheral and the central pain pathways to the feeling of fear, anxiety, and frustration. But the exact definition is the acute pain which occurs following the tissue injury, which is associated with surgery and should resolve during the healing process. This is acute pain. And this normally takes up to 3 months, after which the pain is considered to be either chronic or it becomes persistent, which is what nobody wants in their clinical practice. And unfortunately, the incidence of acute pain after surgeries ranges from minimum of 17% to up to 47.2%. And the literature has shown that the people have complained of severe pain, which is on the score of normal rating, numerical rating score, it goes up to 10, which is like quite high. So we have to know the recent guidelines, and that's why we all are here, that we should know what exactly are the recent guidelines and what does the literature suggest. So the last guidelines, which I'll be talking about with, when they were formulated and the consensus was generated, but according to the British Journal of Surgery, they published an article back in 2020 in which they suggested that the pain management is critical in achieving dreaming. And dreaming is drinking, eating, and mobilizing on day one after surgery. So this is what is the aim of pain management should be for the acute post-surgical pain. So the last guidelines which were shared by the American Society of Pain and American Society of Regional Anesthesia, along with other societies, was last in 2016. So it was back like almost 8 years ago that these guidelines they were published. After that, they haven't updated the guidelines, but there are certain other guidelines which they, along with the other societies like World Society of Emergency Surgery or the Italian Society, they have made certain guidelines either on emergency surgeries or non-traumatic emergency general surgeries or other kind of pain managements, acute pain management, but in other varieties. So I'll be talking first on the suggestions which were given by the British Journal of Surgery, which was done by them, and they did a systematic. It was basically a review in which they had suggested many things, and then I'll come on to the recent guidelines which are suggested by the American and the Italian societies. So the British Journal of Society in 2020, they suggested as you can see on this slide, that they suggested service provision followed by pre-assessment planning, assessment response, pharmacological treatment, and then the non-pharmacological treatment. Now, I'll be talking on individual sets of it, but either them or the American Society in itself, when they did it with the emergency medicine, emergency surgery society, they also recommended plus minus the same thing and the same suggestions. And lastly, I'll talk about the suggestions by the American Society of Anesthesiologists, and they had got it published in back in 2021. So when they suggested service provision, it meant that along with the rest of the services which are being provided to the patients, the most important service which has to be provided is the role of IPS. IPS is the intermediary pain service, and it's being done by the under the supervision of the either an anesthesiologist or a pain physician. And by pain physician means that someone who can look after these patients while the patient is in the recovery room and is being transitioned from the recovery into the ward. And why these consensus were generated? They were generated because not in our country, but in the West, it is more common for the patients to have an opioid overuse. And because of that, they were going into an opioid crisis as well, despite of the fact that we also have opioid crisis in our country. But that's the reason behind our opioid crisis is the lack of availability of the drug. But in the West, majority of the opioid crisis was because of the overuse of the drugs. So they had to make sure that the opioids are being sparsed, and that's why the rest of the concepts they came into existence, like the opioid-free anesthesia and other topics. So we have to. They also suggested to manage the patients, especially those who have uncontrolled pain or who already have complex pain syndromes. Then we also have to educate the patients and their families. Research has to be done and quality improvement has to be done. This is just a snapshot of what they suggested. Then the other point which they emphasized on was the pre-assessment and planning. Now, most of us, they do pre-assessment. Pre-assessment starts from the pre-operative period. And by that, we mean the society meant that we have to plan the optimal pain management techniques according to the patient's surgical procedure. And it should facilitate early discussions to help alleviate or decrease the fear of the pain in patients, in their families. And again, we have to identify the patients who already have pre-existing complex pain, whether it be the use of already be they are already been on multiple pain medications that we have to be ruled out. And then the patient plan for the surgery, intraoperative analgesia plan and postoperative analgesia plan should be done accordingly, because it enables the forward planning for these patients, especially those with comorbidities, and also identifies those patients in whom the pain might not be treatable afterwards. So that's why it is most important. The third suggestion, which was given by the British Journal of that society, was that we already have many tools, and most of you, I'm assuming, and I'm sure that every one of you knows these scales. The most commonest being the numerical scale, which is the ability to rate the pain intensity from 0 to 10. And we do use it on our daily basis. And we do categorize our patient according to mild, moderate, and severe. And we already know that these pain tools or these pain scores, they have to be valid, reliable, practical, and they have to correlate with other scales like visual analog score or the numeric rating score, or in adults, the facial pain scale as well, other than the categorical score, which is mild, moderate, severe. But what we didn't know was that these are the unidimensional pain scales, and they fail to describe the patient experience fully. Why fully? Because in postoperative patients, patient might have pain which is other than the surgical pain, and their ability to tolerate pain may impact its functional recovery. For example, if a patient has had a bad intubation, then the patient would be feeling pain in his throat, but or the patient, after an IV cannulation, difficult IV cannulation, patient's hand might be sore. But these pain scores might not actually be depicting those pain locations when we ask them. We usually ask them where the pain is, the patient is having pain at the site of incision, and they usually respond according to that. So that's why these scores are usually unidimensional. So according to the review, they have advised to use different multidimensional pain scores like brief pain inventory, clinically aligned pain assessment, which is CAPA, and other pain scores, which deals with the patient's anxiety, which also have the cognitive component in the tools. But again, there is a lack of paucity in the literature because of the validation. All of these inventories, they have been studied in chronic pain patients, but not in acute post-surgical pain. So we need further evaluation and we need further studies for their validation and then their implementation in acute surgical pain. Likewise, they have also suggested that the cardiorespiratory parameters in acute post-surgical patients in the recovery room, they are unreliable. Why? Because the patient might be having, otherwise it's usually been known that pain is the fifth vital sign, and most of us, they do it on regular basis in our hospitals and in our institutes. But they can be helpful tool when we are doing it pre-operatively, but post-operatively in the recovery room, they might prove unreliable, or we cannot trust those numbers because of the certain other parameters which patient might have undergone during the surgery or post-operatively, like volume deficit or any other kind of parameter. So we have to use the surrogate measures, which are the opioid consumption. That is the requirement of opioid by in the recovery room, and it's either escalation or de-escalation would suggest that the patient is in pain, or either we are over treating the patients with the opioids. Likewise, there should be the trend. We should be able to check the trends in the pain assessment score over time and again. And we should also be able to identify the relationships between pain and activity and or immobility, because The functional status to be known is very important. Whether the patient is able to mobilize in whatever state the patient is post-operatively is very important to know. And there is, again, is a score for that, which varies from 0 to 2, but within the capacity in which the patient can move on the bed post-operatively. It does not mean that the patient is able to walk or able to jog or able to run within 24 hours, but it means that whatever the surgery has been done and in whatever capacity the patient can mobilize with the less amount of having pain, that's where you can actually make assessment for further need of opioid or any other analgesics to be given. Likewise, additional information on the nature of pain is also very important. We tend to forget that our patient is only requires the opioid or the narcotics in the post-operative period. But it is also very important and very pertinent, especially for the young doctors or the anesthesiologists, to know that you should be able to actually identify and differentiate between the visceral pain, nociceptive pain, or the neuropathic pain. I'll just give you an example. A quick example of that is, for example, if a patient is coming in for a low back surgery, in which the patient already had neuropathic pain, which is the pain which he used to have because of the lumbar disc herniation. And now the surgery is being done, and you are seeing the patient in the recovery room. And when you ask the patient about the pain, you should be knowing whether the patient pain is at the surgical site, post-surgical pain, which is nociceptive pain, or else it is neuropathic pain, which was pre-existing, or is it the nerve pain? So you should be able to differentiate between the two types of pain. And again, the nature of the surgery or whether it's selective or emergency also matters a lot, because that also increases or decreases the pain intensity afterwards. Now, coming on to the management, we have till now we have known that the recent literature suggests that we should be using different kind of assessment for acute post-surgical pain. What about the management? Are there any differences in the recent guidelines or not? So we traditionally have been using non-opioids. Every one of us knows that we use acetaminophen, which is paracetamol, IV, NSAIDs, which can be ketorolac, which we give intravenously post-operatively, or any kind of opioids ranging from morphine, fentanyl to nalbuphine, which we commonly use these days because of the non-availability of the morphine. And we also know that we can use adjuncts, including ketamine, gabapentin, and rest of the drugs. So whatever drug we use, the literature suggests that multimodal analgesia should be used. Again, we already knew that the drugs which act on different parts of the anatomical pain pathways are known as multimodal analgesia. But these drugs have to be with different mechanism of actions and have to be combined with the other drugs, which produces synergistic effect, not the same effect, but the synergistic effect. It should add on to the drug which is already being used. Because what are the advantages of multimodal analgesia? That it allows the use of lower doses of opioids. And again, because the lower doses are used in the opioids, it again reduces the side effects, and we can use different drugs for that. And this is the very famous WHO analgesic ladder. And every one of you knows that initially it was applied for the cancer pain, but later on it came in the management of the rest of the pain conditions, whether acute or chronic. However, the recent literature suggests that as we see the side effects of the opioids more because of the receptors which are involved, and most of the side effects which we encounter are respiratory depression, constipation, and all of, or if not all, any of these can happen, especially the urinary retention, nausea, vomiting, and respiratory depression being the most commonest one in the post-operative period. And among these, nausea, vomiting, constipation are those two most likely causes or the side effects which actually irritates the surgeons a lot, because even if they are doing laparotomy or abdominal surgeries or any other kind of surgery, that's when they get to know the success of their surgery, when the patient is totally pain free along with none of these side effects. And in the long term side effects, patients, because of the overuse of the opioids, can have tolerance, dependence, and withdrawal and misuse. The other side effects which can where the patient can experience are all of these, in which we have to be very cautious when using mixed narcotics, especially nalbuphine, to know the low analgesic ceiling effect. The NSAIDs can have bleeding disorders along with renal and gastrointestinal toxicity, especially in liver for the paracetamol, and NSAIDs for the renal, they are connected, and gastric mucosa irritation. But the literature and the British Journal of Anesthesia in 2021 suggested that instead of the WHO guidelines, one should use procedure-specific post-operative pain management guidelines, which are known as the Prospect guidelines, available on the ESRA, European Society of Regional Anesthesia website. And they have a lot of, like, lot means like 20 or 30, maybe 30. The guidelines are present for the 30 procedures, and they're procedure specific, like laparotomy, for thoracotomy, for laparoscopic procedure, and whatnot. And they give clear indications of to use certain regional technique and certain medications along with that. So along with that, the British Journal of Anesthesia, they published in 2021 another guidelines on why it should be used and why not. So they again, as the British Society of Surgery, they published their guidelines back in 2020. They were more concise in procedures. So, however, the British Journal of Anesthesia gave these suggestions according to the preoperative, intraoperative, and postoperative evidences. But as their evidences were low and they collected their data on the basis of usually an expert opinion or the case reports, so their level of evidence was quite low in suggesting those changes. However, again, they suggested to use the Prospect guidelines instead of the WHO guidelines. And there was another study which was done in 2020, which again suggested that for the chronic non-cancer pain, WHO ladder is inadequate. And they modified the WHO ladder and included the minimum invasive interventions in the step 3, which was the moderate pain, instead of adding the moderate opioid analgesic. And along with that, adjuvant analgesic, and they also applied the integrative medicine therapy in that, which includes cognitive behavioral therapy and the rest of the non-pharmacological therapy. Then there is the recommendation of using ketamine in most of the times, but the recent literature has shown that despite of the fact that it decreases the post-operative morphine consumption at 24 and 48 hours, along with decrease in the pain intensity, but there are dose-dependent adverse effects which are related with the use of ketamine, which are hypersalivation, which is increased in the secretions, nausea, vomiting, and psychomimetic effects. But again, the use of ketamine intraoperatively versus use of ketamine postoperatively, the recommendations also vary. And it reduces the likelihood of transition to persistent post-surgical pain, but currently it is not recommended as a routine part of most of the ERAS strategies. However, its inclusion in the multimodal treatment plan can provide effective in decreasing the use of opioids in patients. And this was the study which was quoted in 2018 last time. Then these were the consensus guidelines. But again, as you can see here in the slide, that the recommendations which were made were grade B or of low intensity or certainty, because of the involvement of the literature, which was mainly the case reports or the there was low the recommendations were lower, except for the fact which was grade A level of evidence, again with low uncertainty, was that the supervising clinician or a physician should be present, which have to monitor the doses, especially when the doses are used in higher quantity or a higher dosage. Then the gabapentinoids, again, we already knew that gabapentin, and the literature started suggesting it back into 2000s. But the evidence again is scarce, and it is usually whatever data is available is based on the chronic pain patients. In the American Pain Society guidelines, it is recommended as a part of multimodal strategies for postoperative pain, but with minimal opioid sparing effects. And they have also mentioned the increased risk of adverse events are associated with gabapentin, especially when the patients, they use it over due. Likewise, alpha 2 agonists, they are also have a role along with clonidine infusion. But whenever we have to start the clonidine infusion, which are alpha 2 agonist, the patient's hemodynamic variability would eventually lead the patient to land up into HDU units where the monitoring can be done. Likewise, dexmedetomidine is very in these days. Most of the people have been using it. Even at our institute, we used it for some time for scoliosis patients. And we eventually had to stop it because of the hemodynamic variability, especially bradycardia and hypotension, which was so severe that we had to intervene in between, not to give it, or we had to give another medications along with that. So it's not recommended, and the literature is again scarce on it. There is mixed literature on it, and the acute this BJS guidelines, they do not suggest its use fully. Likewise, magnesium usually given in 30 to 50 milligram per kg of the patients. Most of the studies which are being done on the use of magnesium and low pain threshold are being done on laparoscopic surgeries. So it can be given up to 48 hours, but again, the sole use of it is not recommended. IV lignocaine, again, it's back in market. Initially, it was recommended for sole postoperative pain management, but and its use of 1 to 2 milligram per kg per hour of infusion was used, but Cochrane has suggested insufficient evidence on its significance. ERAS guidelines, they definitely do have its literature on the elective colorectal surgeries, but the conclusion and the studies further are awaited, and the results are still yet to be shared. And it's not currently in the guidelines to use its sole purpose. Cannabinoids, they are in the market these days. In Pakistan, it's not available orally, but they are used. We do have it in oil form, but there are very few RCTs on the use of cannabis on the cannabinoids on the postoperative pain. But again, the evidence is limited, and it's not recommended by the BJS. The BJS also mentioned about the regional analgesia in the multimodal analgesia techniques. The advantages and the disadvantages are given in this slide. I'm not going in detail into the advantages and disadvantages of each one of these, but we do use epidural, intrathecal, and most of the blocks, they are being recommended. However, the new literature, which was a narrative review done in US and was published in Postgraduate Medicine 2021, suggested the expanding role of chronic pain interventions in the multimodal perioperative pain management. And they suggested the use of procedures like radiofrequency ablation, RFA, which is commonly known, or the cryoneurolysis neuromodulation, and these injections. Now, these injections, according to them, are more favorable in patients who have pre-existing pain conditions or pre-existing pain syndromes. In them, these can prove beneficial, in the post-operative period, maybe not in the pre-operative period, but in the post-operative period, they can prove beneficial. Along with that, these known opioids, which we have already discussed. But this suggested, again, the similar suggestion are being given by the British Journal of Anesthesiology, British Society of Anesthesiology, the surgical, and also the American guidelines also suggest the same, that whatever are being done in the preoperative phase, you have to identify the patients at risk for poorly controlled postoperative pain. You have to educate all patients on pain therapies. You have to provide the needed services like prehabilitation and all. In the perioperative period, use of minimum or opioid sparing anesthesia to be used, regional anesthesia wherever indicated, use and optimize intraoperative pain medication approach, along with the multimodal analgesia and integrative pain services if can be done. And in the postoperative period, you always have to think about uh, tapering the opioids instead of increasing the opioids. So along with these, the abdominal wall blocks, coming back to the regional anesthesia, local wound infusions, and the continuous local wound infusions are being suggested by the guidelines, which was done in 2022 in Italy. And these blocks are mainly for the abdominal wall, abdominal procedures, but local wound infiltration can be done in any kind of surgery, even though weak recommendation with moderate quality, but they have recommended the use of local wound infusion and infiltrations wherever possible, because it decreases the pain intensity at rest and dynamic pain score as well. Then there comes the another evidence of the consensus guidelines, which were evidence based, but these were expert opinion, and they suggested perioperative use of, mainly their focus was on perioperative use of opioids, but they had suggested pre, intra, and post-operative recommendations. And in that, they suggested that, as you can see in the slide, to use, starting from the pre-operative period, they suggested to use judicious use of opioids, preoperative screening for the previous use of opioids and the existing conditions that I said earlier, prehabilitation, that's all the same, which I had mentioned earlier. In the intraoperative phase, as I again as mentioned in the previous slides, use of multimodal analgesia, opioid sparing techniques, and procedure specific, which is prospect according to the prospect guidelines, regional anesthesia should be employed. Then in the postoperatively in the ward, they suggested to use holistically pain tools or the pain assessment scores, and optimize the pain in the recovery area, which is the recovery room just after the surgery. Aim is to improve the pain related functions, which we talked about earlier. If by any means the opioids are needed, they suggested the use of immediate release and the short acting opioids, which unfortunately most of us they don't have in Pakistan. They also suggested to manage the opioid transition to the primary care, and in that, the pain physician's role it comes in with the suggestion of opioid for not more than 7 days. So usually, even in Pakistan, the most commonest drug, the most commonest opioid, which is given in the post-operative period, is tramadol, and the surgeons or the primary team physicians or the doctors, they prescribe it for like 10 days or 20 days post-operatively. So they suggested not to use it for more than 7 days. Then post-discharge or at the time of discharge, the patients should be monitored for the opioid use if they are using. So there are two types of patients, one who are opioid naive, which have never used opioid, or if by any chance they had to use opioid, they only used it for 7 days. But then there are other type of patients who have been using opioids for other causes. And in the West, they are most commonest cause. So for them, they advise to monitor the persistent use for more than 90 days, and to make evaluations in them along with the chronic exclusion of the chronic persistent post-surgical pain. And if the patients are were using the opioids before surgery, we have to monitor whether there is an increase in the opioid use postoperatively from the previous one. So there are these two terms which were new to me when I was just going through the literature, and these are the opioid stewardship and the opioid de-escalation. Opioid stewardship, it came into literature in the late 2000s, and it was a concept given by the Mayo Clinic in US, and they had suggested that, like previously, antibiotics were being stewarded by the infectious disease physicians or the specialist of their own field. So in pain, opioid stewardship should be looked upon, and there should be a person who is looking after the use of opioids, its adverse effects in the patient, and should escalate or de-escalate accordingly to the patient. So in the PubMed, I found 373 results of opioid stewardship, and as you can see here in the picture, that it started these started opioid stewardship concept started coming into being in the late 2000s and 2020s, actually, because it was not present there before that. And it again emphasizes on the concept which was present in the literature since 2012 2011, which was the concept of de-escalation of the medications while the patient is being discharged from hospital, and as the pain decreases. So we have to decrease step by step. Initially, tramadol or the opioids should be stopped, and then the NSAIDs should be stopped. And later on, once the patient is pain free, then the patient should be discharged on paracetamol if not contraindicated. So with this, we also know that there are two other concepts as well, which are preemptive analgesia and preventive analgesia. Preemptive analgesia are the analgesic strategies which are administered prior to the surgical incision or stimulation. That is, when the surgery is planned, one has to give the analgesia before starting the surgery. And because the concept behind it is that it can modify the peripheral and the central nervous system processing of the noxious stimuli, which decreases the central sensitization, hyperalgesia, and allodynia. So all of these can be decreased. But its role in literature is still controversial because not many studies have suggested its use preemptively. However, the preventive analgesia is the prevention of the sensitization at any point in time in the perioperative period, which is using different treatment modalities or different analgesics in the preoperative, intraoperative, or the postoperative time. So it is considered effective when the postoperative pain or the analgesic or the opioid consumption is reduced in the postoperative period, and there are less chances of patients going into or having severe pain, as was um, depicted earlier. And in the curious, which is again in online literature, suggested the advancements in the management of the acute post-surgical pain, but it was a review article which was published in 2023, and it again suggested the same previous things that we had discussed earlier in the rest of the literature, which I had just shown which was done back in 2022 and 2020. So in a summary, we can say that the good evaluation is always needed. Always conduct a preoperative evaluation, including the assessment of the medical and the psychological conditions, concomitant medications that the patient might be using, either the pain medications or the other medications, so that we can have a plan for the intraoperative management as well as for the postoperative management. Always evaluate those patients who have pre-existing pain conditions and always assume that they might have more pain. They might be more difficult to treat intraoperatively, and they might be more difficult to treat postoperatively pain-wise. Always use a validated pain assessment tool to track these symptoms and then so that your plan can be adjusted accordingly. Always use offer a multimodal analgesia depending upon the patient's surgery and the surgical type. Patient centered and the family centered education is also very important, which we unfortunately are lacking in our country and in our institute, and it should again be documented. Then adjust the plan of the management post-operatively according to the patient's condition. And in all of these, which were discussed and emphasized upon previously, there has to be an access to the pain specialist. The role of pain specialist comes in here as well, that you have to, when transition the patient from one phase to another, and if the patient is not being getting treated, especially those who are at the risk of inadequate post-operative pain control, or those who were on long-term opioid or with the history of substance abuse, then pain specialist should be consulted as soon as possible while uh, uh, transferring the patient from the recovery room into the ward. So this is just an algorithm of whatever we have just talked about, depending upon the mild, moderate, or severe pain, and its use, the different use of drugs. With this, I conclude my session for today. I hope that we have touched upon many concepts which previously were present, and most of you must have read about it and already knew about it. But some of them were also new to me in the sense that when I started reading about the latest literature, unfortunately, were no consensus guidelines which were made in 2024 or even in 2023, except for the last guidelines which were present back in 2022, and they were done on the emergency surgeries. But again, plus minus, they provided the same insight into the management and the plan of in the patients to be managed post-operatively. So thank you so very much. Now I would like the session to be open for questions.
Thank you so much, Dr. Asma, and thank you once again for your insight and your very comprehensive and updated presentation on the management of acute pain. The house
So,
is
so
open
do
for
we have,
questions.
because I can't, yes, I can't see the seniors, but if there are any seniors present here, I would request them to give their suggestion or opinion on the current practices which we might be doing in post-operative pain management. And if from the residents or the fellows' point of view, if you have any question, please let me know.
Thank you very much. It was Dr. Leena Aziz here. I'm working
Assalamu
in
alaikum, Dr. Leena.
teaching.
Yes, I know you
Assalam.
from the PSA online lecture series, so I know your name.
Thank you so much. That's why it was very, very nice and comprehensive. We at Ghurki Trust Teaching Hospital, we are doing this acute pain management with multiple blocks. We are doing in orthopedics, and we, alhamdulillah, getting pretty good results. And the only opioid available to us is the Snell pain or Trimol, and to manage it post-operatively, we have seen that the patients who have been given these blocks, they do much better than those who are on multimodal. But we have limitations at certain patients where we do not want to give the blocks or they are not recommended. The multimodal patients definitely it is quite, I think, a uphill task for the pain management.
Exactly.
And my one question to you is, we are doing spine there as well, and we are doing prosthetics we've been using. And in cases in which we find that it's on the lower side, the heart rate and the blood pressure, if you give very low dose and without the bolus doses and titrating it continuously, we did get good results. For instance, when we are doing the arthroplasties, for instance, the knee or hip joints, even if they're neuraxial block, it is to put those patients to sleep. We have been using low doses of prosthetics continuously and monitoring, and we had good results.
Right. So,
So
actually, we had been using Precedex or dexmedetomidine in scoliosis patients who are the children from age group of 9, 10 years, 11 years old to 13, 14 years old. And we had used dexmedetomidine for like more than a year or something, because in our setup, scoliosis is one of the most commonest procedure which is being done on regular basis. And we actually made a protocol on that, and we included dexmedetomidine. But after a while, we experienced, and also the surgeon also told us not to use it further, because they were on their part, they were experiencing delayed awakening of the patient, and they had to evaluate the neurological sign and symptoms. So they were kind of worried about the use of dexmedetomidine, especially when we started it using in the earlier phase. Then from, as you said, that we also used to use it in a very low dose, which was like in mics per kg per hour. I think we started from 3 mics, which was recommended. Then we lowered it down to 1 mic, and then even we tapered it down to 0.5, which is not recommended and not written anywhere. But even on the use of those regimes, we were facing problems in bradycardia and hypotension, along with delayed awakening. So that's why we had to. But again, that's one of the one set of a population in which we used, and those were children, scoliotic children, who might have other abnormalities. But obviously, in spine surgeries, it was not. We never used it in adult patients otherwise. So this was one
Asma,
of
we
the.
are doing scoliosis. Our center is specialized for scoliosis, and we are doing scoliosis, and we are using it. Maybe, as you just said, it's in a certain population, it is not, and mostly they are young adults, very young adults, in which we are doing it. Could it be that the long duration of the surgery could be one of the reasons for the delayed awakening? Because the neuromodulation is continuously going on in these patients,
Exactly,
and
that's
we
so
are
true.
doing. So I personally believe we look it up into so far we've got very good results, and we'll definitely see from this perspective which you have just shared with us that the long surgery, the long hours, definitely we anticipate delayed recovery in these patients. So we'll again review it, because we are doing this 24/7 these cases, and I personally believe it's the very, very long surgery. And unfortunately, we surgeons like to discuss it with the anesthetist.
Yes,
Maybe it is the anesthesia which is causing it.
exactly. Yes, you're
And
absolutely right.
and you don't go scoliosis without neuromodulation at all.
बिल्कुल.
So तो ये एक चीज हो सकती है. अच्छा, acute pain services में आपके hospital में क्या कोई setup आप लोगों ने बनाया? Would you like to share it with us?
Yes,
Acute
thank
pain
you so much
management.
for asking me. Actually, that's very close to my heart as well, because when I joined this institute, which is Yaudin University Hospital, before that I did my fellowship, and I was working at Aga Khan University Hospital, which you all know that they already have a full-fledged setup with the, pain nurses and pain service, and all the faculty present there. So when I joined this institute, it was relatively a small institute as compared to the AKU, but again had more than 200 beds capacity. And I was not too sure whether I'll be able to set up a pain management service here, because initially I really faced a lot of challenge by the surgeons, that they were not too happy sharing their, where patients having, paying the services other than
That's the
their own
usual
service.
story, I think.
Yes.
That's
And
the
then
usual story.
Yes, and then luckily I got this ISP grant, which was for the nurses of that was on the pain assessment and education of the pain nurses. So from there onwards, when I got the grant, I asked the university, because university and hospital, you might be knowing that they everywhere they have cold fights with each other. So from there onwards, when I got the grant, I taught 10 batches of nurses, and from there I selected one of the nurses whom I had taught, or two, and selected actually three of them, of whom they just shortlisted one, and asked me to start off with one pain nurse. And I told the administration I had to actually, fight with not fight with them, but had to have different meetings with them to convince them that we need post-operative pain service. So from there onwards, when initially they said who will assist you, there are, again and again in small setups like ours, or which is not too small but mediocre kind of a setup, and especially the private setup, they have a major concern of non-availability of one nurse at a specific time. They don't have, there is a rapid turnover of the nurses. One day they will be placed in one ward, another day they will be placed in some other ward. You will be continuously teaching, and then eventually you will get to a point that you will be scratching your head and would be like, "Okay, what am I going to do with these whom I have taught, and now they have gone to another, another ward." So from there onwards, I specified one nurse. I asked them, I convinced them that now this is the person who has already have the course and have the teaching and the education to take care of the pain patients. And then from there onwards, then we took that nurse, then yeah, we made the pain protocols, the pain management papers on which we had to the post-operative pain management plan is being documented and written and inserted into the, that was again a whole drill of implementing that. And at the same time, I was also doing pain management clinic, which is chronic pain management clinic once a day in my hospital. So that person who was assigned as pain nurse was also assisting me in the pain procedures and the clinic. So that's how we, evolved from having no person at all in the post-operative pain management to at least a person who can see all these patients, whether the patient is being discharged from the recovery room with an epidural or a PCA or infusions. Previously, the surgeons, they used to see, the primary team, they used to see, and they never knew how to manage a PCA or a patient control analgesia. So they always used to come to the anesthesia team to guide for the guidance. Now they are all streamlined. So
So,
that's summarized.
very well done. We are doing some work, and inshallah, we'll get in touch with you to take your guidance.
Sure, anytime.
Thank you
Sure.
so much. Thank you.
Thank you so
Pleasure
much.
talking to you. Thank you.
So
Thank
same here. So Dr. Tahir have been raised hand since quite a long. Dr. Tahir, Assalamu alaikum. I hope you're doing
Yes,
well.
Walaikum Salam. Tahir here. Thank you,
Yes.
Madam Leena. Madam Leena, actually, already she asked so many questions which I wanted to ask actually. So, two things. One thing
Right.
is the structure of existing physicians, yani structure of pain management with existing physicians, like intro, post-op in the recovery, and then in the wards. So post-op, when patient is in post anesthesia care unit, PACU, the audits should already be there. It should practice in each hospital. I am not talking about Aga Khan or your hospital or Shaukat Khan. In all the hospitals, especially in the public sector, it should be a practice that PACU audit should be written by the person who anesthetized for the surgery. So whenever there is a pain in PACU, the order should be already there. So nurses should know patient needs medicine. Then for the ward, yes, acute pain service team is very much needed in every hospital. And I will just suggest in even in an existing pain service, they should modify the rotations like that. For example, a resident comes, they should stay at least for 1 month or minimum 2 weeks. So they will know the patients, they will start with one patient and they will follow them for 1 day, 2 days, or even 1 week or 10 days like that till the patient is there. So they will develop not only their education, but a better pain management plan for the patients. So I think we have to work on it, that these sort of setups should be in each hospital.
Sir, can I add on to that point of yours, because that's a very important point. And as far as like why I always give the example of my setup, because it started all from the scratch. And as you has rightly mentioned, the presence of a resident, the what I assume and what I think the most of the institutions, they have the limitation of is that they have limited number of either number one, especially in the private setup like ours, they have a very limited number of residents who are, if they are post call, they won't get enough time to leave their operating rooms and go into the wards to just look after the patients along with the pain nurse or the pain physician. So yes, it should be made a routine. And I think what from my experience, what I made sure that every post-call resident should go and see the patients along with me, either me or with my pain nurse if I'm busy in the operating room. So they have, uh, they give an over to the on-caller that these patients are on the floor for the pain management, and one have to see afterwards, either when they get free from the OR or later the next day. So that's how one of the limitation of not having too many residents or the working force. This can it's not it's not I'm not saying it's not necessary, but where there is a limitation of not having a full acute pain management service or a team, so that's how you can overcome this problem, like I
Yes,
did.
but just sorry, I'm taking time. Just 1 minute, one more comment. You know, this pain is an integral part of this fellowship. Okay,
Right.
you are asking questions in the exam. Few weeks back, we had a course about this part two preparatory exam, and none of the candidate had seen that nerve muscle stimulator. But you are asking them in talks and in the exam. None of the residents or candidates, they had seen this PCA pump, but we are asking them in the exam and they have to answer them. But again, it little bit irritates me why we ask the things which we don't teach. So if we
Actually, it
have
varies from institute to institute. Most of the institutes these days they have PCA pumps. They have
no, no, no.
the so
Majority of
we
the candidates are coming from the government sector. So we have to just, we have to try about it. Not only focus on the, some specific hospitals. This is just my opinion that, your lecture, everybody is listening, majority from the government sector. So they should also get all these facilities and they should know these
You are
things. That's my
absolutely right,
concern.
sir. You are absolutely right, and I'm surprised that it's not available there in the Punjab sector, because whenever I ask the people of our government sectors like civil hospital or Indus Hospital, or which is a semi-private, or Jinnah Hospital, whenever I meet their residents and they have a knowledge of PCA pumps, and I was surprised, and because even I had an assumption that government has hospitals, they don't have resources, and they have, because of those limited resources, they don't have these gadgets, fancy kind of gadgets. But later on I was told that everything is available, and I was surprised that, oh wow, that's so great that now they are spending things on the gadgets which are useful for the patients. But it is
Yes, sometimes
surprising
the
me now
gadgets
that
are
yes.
there. Sometimes
Yes.
gadgets are there, but not used or
Yeah.
shown to the resident.
Yes,
Yeah.
you are absolutely right, and I'm surprised that people, the residents, they never had an idea about the PCA pump.
Yeah.
Thank you so much, sir, for your input. Dr. Asma,
Yeah.
we have a question from one of our participants. If you
Mm-hmm.
would like to comment on it, the role of acute pain management in day case surgery and the role of different blocks and concerns.
Definitely there is a role not of the regional anesthesia, not even not only in the daycare surgeries, but it is recommended for any kind of a surgery in which it is indicated, either it's the upper limb block or the lower limb block. So the latest research and the latest consensus and the guidelines, they suggest the use of peripheral nerve blocks uh, in any kind of surgeries wherever it is indicated. As far as the daycare surgery is indicated, the use of ERAS, which is enhanced recovery after anesthesia, that's something different, and it's usually been done on the abdominal surgeries. But for the daycare surgeries, the because one of the concerns which arises after the use of nerve block is the uh, mobility of the limb, which concerns the surgeon as well as the anesthesiologist both at the same time, whether the power is back or not, whether the sensation is back or not, and if the patient is in the daycare, whether the block which has been given to them will, the patient will get recovered or not. But again, having said that, the kind of procedures, because these days even the guidelines for the induction of the patients in the daycare have also changed. The surgeries which were previously not done in the daycare, now they are being done in the daycare. For example, small children or other abdominal wall surgeries which were previously not indicated as a daycare surgery. So after the change of those criterias, now people have been using the other kind of blocks like rectus sheath block or total abdominal wall block, in which the motor power is not being assessed too much, or other sensory blocks more as compared to those blocks in or the other kind of modalities. So yes, it has been indicated.
Okay, thank you so much. There's one more question, and probably the participant wanted to know about the incident of rebound pain in your setup.
If you can unmute the participants and they can ask directly to me, that would be more, I'll be able to understand the question more.
I'm not sure if the participant is.
Assalamu alaikum.
Kashif here. Can you listen me?
Yes, we can hear you.
Madam, my question was, what is the incident rebound pain? As we nowadays we are using multiple blocks,
Right.
and patient is usually not aware of this situation. That suddenly he starts feeling pain. So, how you deal with these situation? Uh, how you can you manage
So
this
are you asking about the patients who have undergone the regional anesthesia as a plan of
or
management
any block?
intraoperatively, or any block, and then later on after 5 or 6 hours when the effect of the block is wearing off, they start having pain? Are you asking about that?
Yeah, exactly.
Okay, so in our setup, we do give a nerve block, and then in the post-operative, in the period, like when the patient is being discharged from the recovery room into the ward, that's approximately 1.5 to 2 hours stay in the recovery room. Then we write in the post-operative notes the use of intermittent opioids, NSAIDs, and acetaminophen on for like for 24 hours to 48 hours. So intermittent analgesia on regular terms, but as in not continuous infusions, but intermittently and on PRN basis is advised, along with the regular use of NSAIDs and paracetamol where indicated. Like the patient is not renal failure, the patient is not in having bad LFTs, and the rest of the thing. After excluding that, we do include it in our post-operative pain orders. And we do have and have had encountered patients complaining of severe pain later in the night, 2 o'clock or maybe 3 o'clock, but that's hardly that's the incidence is hardly 4 to 5% maybe. And those are those patients who already had those were the ones who were in that group of patients who had pre-existing uh, complex pain syndromes, or they were more anxious or more they were already on some kind of medication before coming into the surgery. So in those kind of patients we have seen that.
Can I add few words in? This is a very good question, actually. Many times you just put a very good block, and next morning your pain team goes and the patient complains that in the middle of the night he was shouting with the pain. तो इसमें होता क्या है प्रॉब्लम? मेनली जो आपने मेंशन किया, जो PRN मेडिकेशन है ना, दैट इज द मेन रीजन. क्योंकि जो नर्सेज होती हैं वार्ड में, ईच नर्स हैज मेनी पेशेंट्स, 5, 6 or 8 पेशेंट्स, समटाइम्स 10 पेशेंट्स. So they don't go to the patient until the patient or the family they complain about the pain.
Yes.
तो यहाँ पे प्रॉब्लम आती है. तो प्लीज फॉर एटलीस्ट 2 to 3 days some medication should be put as a regular medication. So you start the regular medication before the effect of block wears off. So then the medication takes over, and then after even the block wears off, so patient will not have pain or minimal pain. Okay, so my practice was to keep the paracetamol, acetaminophen, and any non-steroidal, ketorolac, pericoxib, whatever, as a regular medication for at least 3 days. And then on top of that, either tramadol or morphine or whatever, any opioid as a PRN. So it will cover any breakthrough pain as a PRN medic.
Right.
So that was my scheme.
Yes, that's the correct regime. That's the correct regime.
Thank you, sir, for your input. And thank you once again, Dr. Asma. I cannot see any further questions in the message box. So if we don't have any question or comment from the audience, we can close the session.
I'm really grateful to you, Dr. Sada, for inviting me over. Thank you, Dr. Tahir and Dr. Amir Furqan, who are the senior faculty over here, for joining this session at this hour of night. And thank you, STSP, for giving me an opportunity. I'm really grateful to all of you to be present.
Thank you so much, Dr. Asma, for your time. And it's so great to have you. And we are looking forward to have more input from STSP Karachi chapter.
Thank you so much. Thank you.
Thank you so much. Thank you.